I'd like to take a minute to talk to you about what is the meaning of the term immunotherapy. Many patients ask about immunotherapy, and unfortunately, this word is used to apply to a number of different treatments. And so I thought it would be useful just to differentiate between them. The standard concept of immunotherapy is related to what they call monoclonal antibody drugs. And these are essentially designer drugs. They are made to attach only to a single certain type of receptor on the surface of a cancer cell. And typically, cancer cells are tested for those receptors. Most commonly, you have probably heard about it in breast cancer, where there's estrogen receptor positivity, progesterone receptor positivity, but that's not specific. But then when we come to HER2-neu or HER2-neu positivity, there is a single drug called Herceptin that was designed particularly to be attracted to those receptors and to kill the cells. Now, this is a great idea, and it can have endless applications. One of the issues that is a problem in utilizing these medications is that there is a multiclonal component of cancer. In other words, not all cancer cells in a single person's body with a single tumor type are created with equal receptor status. So in the case of a situation where a person is HER2 positive by their FISH test that somebody did on their biopsy, traditional evaluation does not identify the percentage of cells that may bear that marker. And although it may be in high enough concentration for the patient to be considered positive from the tumor biopsy, nonetheless, this may not be the same status for the circulating tumor cells and stem cells that are shed from the primary tumor. So many regimens are based on responsiveness to immunotherapy drugs, and they're usually designed to be given at least over 1 year period of time. So nowadays there is rethinking about this long period of time, and sometimes patients are recommended 6 months of immunotherapy and 9 months of immunotherapy, although still the standard of care is 12 months of immunotherapy. And although I recommend that as well, I noticed that there are many patients who have primary tumor that's positive and susceptible to a certain immunotherapy agent, but then when it comes to the circulating tumor cells and stem cells, they are not. So it's just something to be aware of. Now, a lot of patients have encounters about the potential use of immunotherapy in cancers such as malignant melanoma. The radical change in treatment and success in treatment in melanoma came with the advent of utilizing Keytruda and Opdivo, two immunotherapy drugs. And although we've now been successfully using these for a number of years, we also observed that there are certain mutations in the case of melanoma patients that indicate a resistance to immunotherapy. And when the cells are exposed to immunotherapy agents, it motivates them to change their form from a squamous cell and revert back to the embryologic origin of skin, which is a neural crest cell. And these neural crest cells are resistant to all treatment. So I do have in my practice some melanoma patients who have refused any kind of immunotherapy, any kind of chemotherapy, and been treated very, very successfully with other methods. So it's just a matter of trying to understand when these drugs, these designer drugs, are appropriately applicable, and perhaps sometimes when not. Now, other ways of using this word have to do with immune boosting. But in the traditional sense, immunotherapy refers to these drugs that are designed specifically to attach to a certain receptor. They can be IV or they can be oral. However, that's the standard definition. Immune boosting treatments are another matter, and there's a myriad of them, and I usually refer to them as that and not immunotherapy because it's a little bit confusing. I hope I've helped you understand this issue a bit more today. Thank you.